So yes, like Paul said, I'm just going to be reporting on a global systematic review that we have done about gambling and the evidence of harms related to gambling. So just before we get started, I'd just like to take a moment to acknowledge the Bichigal people of the Ora Nation, who are the traditional custodians of the lands of which we are meeting on. And I would like to pay my respects to the elders past and present, and any Aboriginal or Torres Strait Islanders who are present today. I would also like to take a moment to acknowledge the other collaborators, especially for the systematic review, Louisa, Michael, Heather, Rachel and Sam, as well as the research assistants who also assisted throughout the project. So Michelle, Rachel and Sophia themselves, and just some acknowledgements there as well. So essentially for gambling, we understand that it is increasingly being recognised as a public health issue. So we constantly get reporting that gambling is increasing in society, and especially about the medium's used to gamble. So systematic review estimated the prevalence of problem gambling is about 2.3% globally, and that was conducted in 2012. And we recognise that the gambling-related harms that one can experience can be quite varied, and that it can have impacts beyond the individual gambling themselves. So it can impact their families, society, and their communities itself. So what we really wanted to do was to synthesize what literature is available now. So looking at sort of the past decade, what can we find about gambling data, about the prevalence of gambling, as well as other gambling-related behaviours and the harms that they experience. So we did a systematic search of peer-reviewed literature bases, as well as grey literature reports and publications. So looking through websites, looking at experts and seeing what reports would come back to us. And to be included, essentially, we're looking at any papers that were published since 2010 that reported anything to do with gambling. What I will be reporting on today is just looking at representative cohorts. So looking at population data, essentially. So this is what we did, very small, but essentially we, at the end, got about 367 cohorts of people that were reported some form of gambling data. Looking at just representative studies, we found 224 cohorts, which I will be reporting on today, looking at 59 countries and territories. So quite a bit lower than how many countries and territories are available. And within these cohorts, we were looking at about roughly 1.5 million individuals, quite older, in that the mean age was 29. And a lot of our studies were coming from high income. So looking at Australasia, Western Europe and North America as being really where the data lies at the moment. So looking at globally, so once we got all the data, we synthesized it down. This is what we get for the prevalence of gambling in adults. So if we focus in on the higher gambling countries, we can see that Australia is there, sort of North America is also there, and certain pockets in Europe itself, but also noting there is quite a large area where there is no data at all. And then the evidence gets even smaller once you're looking at minimum low risk. So this is where people who have gambled then get asked, what is your risk of gambling? Have you engaged in any form of harms related to gambling? And this is if anyone scores above a 1. So there is some form of risk that they've experienced. And we can see that, again, there is quite a sparse. America is sort of looking at being the heaviest, with Australia also being in the mix. And then once you look at problematic gambling, so these are people who have gambled in the past 12 months and have experienced significant harms, we can see that, again, the data really then shrinks down. And we're seeing that America sort of leads the prevalence, with Australia sort of being at the more lower end, which was a bit surprising, given our media coverage. When we look at adolescents, the data again shrinks. A lot of the data is from Europe because they have a high school survey that looks at gambling and other behaviors. But we can see again that there is quite a variation in reporting of prevalence. And again, once we look at other risks, so the likelihood that they're going to experience at least a risk, the data then gets smaller, but quite prevalent in that Australia, North America, we're seeing quite a large number of adolescents experiencing harms. And then once you look at problematic gambling, again, data shrinks again, but we're seeing that Australia is there. Just a caveat with the Australian, there's only one study that reported on it. So very minimal data set there. So when we compare across that cascade, we can see that for adults, there's more data than adolescents, but we can really see that trend of people gambling and then seeing that conversion or how many people who gamble would then be at risk of experiencing harms. North America, with that jump for minimum low risk, it's essentially just because some studies will only look at low risk, so I couldn't include them in the any gambling rate. When we look at it globally, so if we're looking at the number of people, we can see that out of the 5 billion people who live in the world, this is based on 2021 population data, we're looking at about 2 billion people will have gambled at some point in the past 12 months. And of those people, you're looking at about 400 million people are at risk of experiencing a harm. And then about 64 million people would then go on to have quite significant harms experiencing related to gambling. So really just shows that even though, you know, the rate might be quite low, it's actually quite affecting quite a large number of people. We also looked at specific forms of gambling. So what are the actual gambling activities that people are doing? And we can really see that there is a change within the actual individual activities themselves. There is a caveat that online gambling was very poorly asked. So it will be interesting just to see for future research how many new surveys start asking about online forms of gambling, because it is being very much pushed into that medium. But even with the low number of studies asking about online gambling, it is quite a prevalent form. And electronic gambling machines, so that's your pokies, that's sort of your slots that you will find. We can see that people who are experiencing problematic gambling, that is sort of one of their main forms of gambling itself. When looking at other gambling related behaviors, so things like how much money they spent, how much time they spent gambling, there was very limited data here. So just putting it out there that because there's such variation in how they asked the question and what types of behaviors they were asking about, even asking about what types of help seeking. So did they call a helpline? Did they go see their doctor? Did they enter treatment? Because there's so much variation, we really couldn't meta-analyze it all. It just didn't feel appropriate in that sense. But when looking at harms, they really range from financial, mental health, crime, relationships, education, and work, with mental health being the most asked about harm there. So very much looking at depression and anxiety from that point of view. And looking overall at help-seeking interventions or treatments, 13 representative studies reported on it with 9 other general cohorts. So anyone could have answered the questions, but yes, quite a varied range of questions there. So just to wrap everything up, so even though we were able to find roughly just over 360 cohorts, there is quite still significant gaps there. So like I pointed out initially, 59 countries and territories had representative data, but there's 209 countries and territories with gambling legislation being found in about 80% of global countries. So there's quite a lack of data available for us. And we estimate that a significant proportion of people who gamble are at some risk of experiencing gambling harm. So you're looking at about 1 in 6 people who gamble will go on to experience a gambling harm. And sort of, caveat always, more research is needed. But that is all.
Just hold on for 1 sec. Is there any questions for Lucy?
No. So the way that a lot of these studies will measure problem gambling is through giving a measure, and the measure themselves vary quite a lot. So the most prevalent one is the Canadian Problem Gambling Index. And then a lot of studies will then use a 9-question subset from that measure. So not many of them rely on the DSM criteria of problem gambling or disordered gambling. So there's a lot of variation, and sort of when you look into the literature around the measures, a lot of the measures aren't very well researched themselves. So out of all the measures of gambling, only one of them had validity tested of the measure before it was administered out. So there's quite a lot of issues within how they measure problem gambling. And then even now, when you look at the literature, a lot of them question what are the thresholds within those measures of, so a lot of caveats to be placed there.
Great, thanks very much, Lucy. Okay, we now have a joint presentation from Associate Professor Rebecca McKetin, who's leader of the methamphetamine program at NDARC and one of Australia's premier trialists in relation to methamphetamine dependence, and has an extensive history there. And Simon, who has joined relatively recently with a background in criminology and sociology, focused on gender issues and related concepts. So over to you, Rebecca.
Thank you very much. It's a bit intimidating after the previous speakers. I hope I can keep up. But anyway, I'll be starting this presentation and handing over to my esteemed colleague, Simon, who will be very entertaining. So please hang on. I've got 20 slides and 10 minutes, and he's got 3 slides and 15, 20 minutes. So I'll get on with it. So I've retitled my talk from integrating contingency management for methamphetamine use into routine clinical care in Australia, because it seemed very long and boring, to what if there was an effective treatment for methamphetamine use disorder and we didn't use it? Because that's actually true. If we worked, I'll just acknowledge all my colleagues and international experts who have helped us with this. It's not just Simon and I. So this is a summary of systematic reviews that Michael Farrell and myself and various other colleagues at NDARC put together. And we're looking at different interventions for stimulant use. And you can see a lot of them have no effect or a potential effects, but not clear effects. One of the standouts, and obviously we don't have an effective pharmacotherapy or approved pharmacotherapy for methamphetamine at the moment, but of the behavioural therapies that are available, what we can see is contingency management is one of the ones where there is really clear evidence for a decrease in methamphetamine use, and that's manifest as an increase in abstinence, which this intervention is designed to bring about. So for those of you who can't see it very well, basically CM is the only treatment where we have really clear evidence of its effectiveness, but also that it's not to say psychosocial interventions aren't effective, but of them, this is the only real standout one where we're getting really strong treatment effects. But at the moment, it's not really implemented in clinical practice. So this whole project is about understanding why that is the case and what we can do about it. So hands up if you are familiar with contingency management. Okay, that's good. When we were doing research with people in services, and Simon's going to talk about this later, a lot of people said that they're familiar with it, but they're familiar with incentivising behaviour more simply. So you give people, your children a star if they do their homework, or someone a lolly if they do a HIV test or something like that. But in contingency management for substance use kind of starts with that simple premise. If you give a drug-free urine, you get a voucher. But it's actually quite complex. That's probably one of the reasons it hasn't been taken up well in practice. You start with a really small reward, like $3. If you can give 2 clean drug-free urine, in a row, then that goes up to $5, and it keeps escalating. And you might get some bonuses. So there's an increased incentive for staying abstinent. There's also a stick where if you give a drug-positive urine or you don't give in your urine sample, it resets back to 0. So that's punishing effect. And together these things work. There's also a variant that Nancy Petrie developed in the USA where you use a prize draw, and rather than winning a set amount of money in a voucher, you actually get a number of draws out of the fishbowl. But it's essentially the same principle. It's a bit cheaper. I guess our question in this research is, how can we actually use this intervention if we're not using it currently? How can we put it into practice to help people who use methamphetamine in Australia if they want to reduce their use? And we've got a few different aspects of this project. And today we're going to talk about 2 aspects. I'm going to hopefully go very quickly over a few slides where we've interviewed people who use methamphetamine to find out if we were to do this, would they actually do it, and what would they expect? Present a little bit of those results, and then Simon's going to come up and talk about what service providers, healthcare providers think. So this was our lovely survey, and this was the the picture that the Star Observer put against the little editorial that I wrote, and in a very short time we had to close recruitment. It just got overwhelmed, and you'll see in a moment, largely men and a lot of gay men. But still, we got data from 268 people who used methamphetamine at least weekly in the past year. They lived in Australia. They had to have a valid Australian phone number to do the survey or get the reward at least at the end. We reimbursed them $30 as a gift card. A very skewed demographic toward male. Unfortunately, I was trying to keep the survey open to get more women, but it was just getting overwhelmed with men and I had to close it. And a quarter LGBTQI+. Really unusual demographics in that 47% were in full-time employment and only 12% non-employed. That's not what we see in treatment. It's not what we see elsewhere. Just over half smoked, which is what we're seeing in other data sets. And similarly to other data sets, about half have received treatment in the past for meth. So amongst the things that we asked people, we said, this is actually a question from the General Help Seeking questionnaire, and you can modify this to any circumstance you like. We said, if you're having difficulty controlling your meth use, how likely is it that you'd seek help from the following places? Now, we'd already explained what contingency management was and asked them a whole lot of questions about it. So in our options at the top, and I don't know if I've got a pointer here, but you can see at the very top, it's got contingency management, the treatment we've just described to you where you get paid for not using meth. And then we've put a whole lot of other usual suspects here. And for each of them, they can rate extremely unlikely to extremely likely. This is just the proportion who said likely through to extremely likely. And they're all pretty popular, which is good. But it's interesting that contingency management is up the top and it's on par with our other major treatment modalities. So from the perspective of the people who did this survey, if they were going to seek help, they would give it a go just as much as I give counselling or anything else a go. A couple of other things we found. While they're happy to give it a go, this is quite interesting. They want a lot more money than what CM gives them. So a classic CM model starts at about $5. This is based on our review of the models that are out there. And the most they can earn over 12 weeks is $1,500. They wanted a median of 67, so basically $70 to give it a first go for their first clean urine. And up to $4,000 for the total 12 weeks. But it's that initial starting value that is really discrepant. they're not going to give it a go for $3 or $5. And that's got to make sense. And also most of them wanted other treatment. So we know that we need to integrate this with other treatment. They wanted counselling. They also wanted withdrawal support. And as Simon found out when he interviewed people who were using meth in his qualitative study, they're like, well, we can't just stop using, like we need some support pharmacologically to get through this. So I hope I've gone fast enough. But the next question is, can we do it? So Simon, well, actually, Zach Wilkinson and I interviewed people from a few different health services around Australia, drug and alcohol services and primary care services that do interact a lot with people who use meth. And we did focus groups, and Simon was kind enough to analyse the data for us and present. So thank you, Simon.
Oh, good. Yes, so I'm going to talk about the focus groups that Rebecca and Zach conducted. So they did 6 focus groups with a variety of clinicians and healthcare workers from New South Wales, Victoria and Western Australia. And the people who participated in the focus groups came from a lot of different backgrounds. So we had clinicians, we had nurses, we had peer support workers, we had outreach workers, medical staff. So quite a broad range of viewpoints. There was a general agreement that CM had potential, but there were a lot of caveats. People were quite hesitant, and there was a lot of disagreement within the focus groups themselves, to the extent where it got quite heated at certain points, which was interesting. So one of the really big things that participants kept coming back to was ethical concerns and philosophical concerns. And there were a lot of different things within this. So people were concerned about how voluntary it would be and the risk of coercion. So they were worried that paying people to engage in treatment would create an undue influence. And because of that, it would reduce people's capacity to choose whether or not they actually wanted to engage in it. There was concern that this would be particularly pertinent for people experiencing financial hardship, because the thinking was, I don't have enough money, this person's offering me $5, $10 to do this, so I'm going to do it. I don't actually want to do it. So what is the ethical thing to do here? There was also concern that it would be coercive in the way that the clinicians would be imposing treatment goals onto these people, that they would have to be forced to do something that they didn't really want to do in terms of reducing their drug use. So that was a big concern. Shame and stigma was also quite a big one. There were concerns that the punishment that came out of having rewards revoked would create a sense of shame in clients as well as clinicians. One person was talking about how they would feel a sense of shame only offering someone $5 or a salad bowl for all the hard work that they put in to not taking meth. And they said, you know, it just feels so bad. This person's trying so hard and they get a salad bowl. Like, that's not great. There was also concern that this idea that you had to stop using drugs was another iteration of drug-related stigma, that drugs were inherently bad and you had to stop. You've lost control of your life, and so you need us to intervene and take control, and we're going to do that by giving you money and taking away money. There were also concerns that this program would further marginalise a lot of groups. So, as I mentioned before, the financial incentive might inadvertently heighten the level of disadvantage, because the people who would benefit from it and did need the money actually wouldn't be able to do it because they lived too far away, or they weren't able to go to the clinic every day because of work or whatever reason. So the people who would benefit from it couldn't do it, and so they would be further disadvantaged. There was also worried worries about people, like, infighting is the wrong word, but tensions among clients within a clinic. People who were on OAT saying, well, if that person gets to do this, why can't I? I also have a dependency. I'm also getting treatment, but they're getting money for it. We're doing the same amount of work. So this is unfair. But by the same token, they have OAT, and people who use meth don't really have anything aside from psychosocial treatments. But there was this concern that this disparity would create a lot of tensions. There was also worries about the politics and the optics of the program. So some people were concerned that it would be perceived by outsiders as we're giving money to drug users. And this is not a good thing. We need to drive this out of our communities. There was particular concern about conservative news outlets getting hold of this and twisting it. Okay, that's done. There was a lot of concern about the potential damage that this could have on the therapeutic relationship. So part of that was clinicians saying, my role is to offer treatment to these people, not to give them money for doing what they should be doing already. And because I'm taking money away or giving money, I'm put into a very awkward position. And I don't want to do that. So people thought if we could outsource this and do the testing elsewhere so that I'm not the one doing it, I remain the good guy, then that would be possible. But I want to be delivering healthcare, not delivering money or taking money away. There was some discussion around whether or not CM could fit into a harm reduction context. There was this idea that harm reduction and abstinence were diametrically opposed, that they were completely incompatible. But what happens if someone comes into a harm reduction clinic saying, I want to stop? That didn't really come up. But there was this idea that you cannot put in an abstinence-based model into a harm reduction clinic. So as a solution to this, some people said, well, what if we have, where am I? Oh, what if we change the focus onto clinic attendance instead of abstinence? We can get people into the clinics, engaging with healthcare workers, and we can pay them for that. It takes the burden off them and it makes it a lot easier. But then other people said, well, just because you have them in the clinic doesn't mean they're going to engage in treatment. You can lead a horse to water, but you can't make it drink. The logistics of testing was also quite a big concern. Who would be doing the testing? Who's paying for the testing? How would the testing results come back in a timely fashion? If we had it off-site, which was greatly preferred, who would be doing that? If it was going to be done at the same day, how would those results get to us within a few minutes? There was also a big focus on the need for adjunctive care. That it is not enough to just pay people for engaging in treatment, that you had to offer them some kind of therapeutic support, you had to offer them community support, you had to give them a much more holistic approach if this is going to be successful. It needed to be client-centric and it needed to be flexible. There was a big emphasis on clients being able to choose what treatment goal they had rather than clinicians saying it's either this or nothing. The reward system was highly contentious. There was no agreement on what it should be. However, there was a general erring towards cash. Some people thought if you give people cash, then they can spend it on drugs or alcohol, and I'm not comfortable with that. But if we don't give them cash, then it looks like we don't trust them, and we should be able to give them their freedom. If we give them gift cards, it'll make me feel a bit safer, but at the same time, they wouldn't be able to spend it on things that would be useful. If it's government funded, then they might only get gift cards that could be spent in very restricted places. And while that might make the optics look better. It'd be worse for the people. So yeah, there was a lot of different tensions. Ah, there's my slide. With the prize draw in the lottery, some thought it would be beneficial because it promotes social engagement, but it's also a form of gambling, and the lack of consistency in the reward value could be deterring. If you win $100 one day and then $0 or $2 for the next 4 days, that's not a great incentive. One participant also said that it could perpetuate the dopamine rush associated with drug use, so that you're just swapping drug use for gambling as a form of treatment, which obviously is a bit counterproductive. So, what's the time? Oh, did I?
Yeah. So we have 10 minutes.
10 minutes. Oh, I'll keep talking then. Yeah.
Maybe if we allocated 5 minutes, then.
Oh, okay. Oh, this is great. Oh, it helps through that. I was quite concerned. Well, what am I do? All right. So going back to the in-depth interviews where I asked people who would be using this treatment what they thought about it, they really loved it. They thought it was a fantastic idea. And in some ways, their concerns, their thoughts dovetailed with what the clinicians were saying. They said, we really need additional support, which Rebecca said before, and clinicians said, we need additional support. But the people who were going to be doing CM, they said, I would love to be abstinent. I've been trying to get off this stuff for years. If I can get someone to help me get off it totally, that'd be fantastic. But clinicians were saying, well, we can't do this. We have to let them choose for themselves. We have to have a harm reduction approach. We have to be very, very flexible. It is bad for us to only have abstinence as a goal. And I think there was 2 participants who said, I don't want to do abstinence, which I thought was really interesting. As Rebecca pointed out, they said that the reward system has to be a lot higher. I'm not going to stop taking drugs for $5. It's really hard. $5 is not worth it. And clinicians kind of said that, maybe not really. They were a bit ambivalent. But yeah, exactly. But there was a very, very strong preference for cash because it was very, very, you can use it a lot of different places, but also having something and being like, this is the money that I got. This $20 is what I got from my hard work, and seeing cash in your wallet, the symbolism of that was a really big, was very, very meaningful. Interestingly, there was a lot of suspicion around other people who would be doing the treatment. And this wasn't raised in the focus groups. Cheating wasn't raised in the focus groups. But the people I spoke to said, I wouldn't cheat, but they all would. I would be the good person, but I wouldn't trust them. I don't know how that would play out in a practical setting, but I thought it was very, very interesting that there was this same idea that there would be tensions within the people, within the client pool. Yeah. I might wrap it up there. So we have some questions.
4 or 5 minutes for questions. David?
Slightly different don't work and maybe on settling, so the value of whatever $10 incentivizing. I think it'd be great to have as an option, given that it's been but it is going to do different demographics to find feasibility.
Yeah, so that survey we did ask about would you prefer cash and how much you would want, and that was part of that. And we're still investigating, analysing that data to see whether it varies by demographic. To be honest, I don't think it does that much, but I just think that small amount was pretty universally not adequate. If that's what you mean.
I just mean, yeah, like if you've got street-based people who are relying on settling for their own income.
Yeah.
Instead of 10 months in the first day,
Look,
that's not going.
I was analysing this data about 5 o'clock this morning because I'm
Yeah.
jet lagged. And what I was actually seeing in that data was that the people who are lower incomes and in that situation preferred the fixed schedule, the one that I presented earlier, where you know what you're getting, not the price draw model. They, like Simon said, they wanted that cash and it gave them the ability to plan what they're going to use that money for. They didn't want a prize. Yeah, it was the predictability that was critical to them.
Thank you.
Yeah.
Susie?
Sorry, thank you. We know that there's evidence for contingency management, and it's published in our guidelines in terms of what's effective and what works, and yet we rarely do it in any real way. I mean, I know of some clinics that might offer more what they perhaps perceive to be more palatable things, like, you know, food voucher, or exactly as you're saying, like something that perhaps we find more palatable, like acceptable, rather than cash. And I'm just curious about that, and what would be a way of sort of jumping over that barrier and listening to the evidence around it, because it is an area that I'm not that familiar with, but know that there is literature to support it being very effective.
I mean, that is what, do you mind if I go for it? Yeah, I think that is what we're trying to get at. And there's quite a lot of literature looking at reasons why it hasn't been implemented, and all of these. There are a number of different barriers that have been identified, that the complexity of it, the fact it doesn't fit with the way the treatment system is structured. But I think the new thing that we have found, and Simon's tried to articulate, is that there is a fundamental conflict with a therapeutic alliance. And then a therapeutic alliance should work with the client to identify the goal of treatment and how to get there. And with contingency management, the goal is abstinence, and that's on the table to start with. And how to get there is drug-free urines.
Simon? Simon, please wait for the mic, because I didn't realise there are actually online people.
Okay, Simon Lenton. Hi everyone online, Simon Lenton from Endry here. Great presentation. You know, I just wonder whether, if it was offered as one of the components of treatment at the stage after people have been given the options and they can choose abstinence or a controlled option, that it might be useful. And the other thing is, why can't it be running alongside clinical work that's being done? Because that would seem to get around it. And if people are choosing it, then it's not being forced on them, right?
I think that's the essence of it. We've got to implement it in a way where people are themselves choosing it, and that it is parallel to other clinical processes, so that it isn't impacting on that client clinician relationship. Yeah, how to do that is the next thing. Yeah. And we do have, in the US, they've developed an online app where you can actually do the drug testing remotely. And then there's, you know, it's a bit like gambling, little coins dingle down the screen, and you get an amount of money for each drug negative test. So, I mean, it costs money, but they've actually put that on an online platform, and you can then sign up for that, and then you can opt into counselling. And that's in America, and it's private, and it's probably going to be expensive. But if we could maybe do something like that and have it in conjunction with drug treatment services, I think that would be a good model.
And if it was piloted in one setting.
Simon, can you use the microphone, please? Sorry.
I just going to say, even if it was piloted in one setting where the viability of it was demonstrated, then that might be.
It's definitely a possibility. And I think one of the things that I felt in the focus groups, because Simon had the pleasure of analysing them, but I was conducting them, we actually wanted to talk about the logistics of things, and we didn't get that far. And when you've got a group of people, and you've got maybe 2 people in the group who love it, and 3 people who hate it, and other people are going, what is this? You don't get movement. And I think that's one of the reasons it hasn't been taken up.
also one more little thing. That was a big thing, saying we should offer this as an additional treatment and make sure people know that it is one more treatment within the suite that may or may not work for them. But that still didn't abate concerns around whether or not it would be voluntary. So it was this almost dualistic thinking of, if we had it, in essence, it couldn't be voluntarily entered into, but we want it to be there so people can voluntarily enter into it, if that makes sense.
Some people just can't please them.
Can't please them.
It's, yeah, it's, I was going to say, it's interesting if you look at the different the ethical framework for providing healthcare. There are some real issues here around making that decision for someone what the goal is and paying them to do it. It's quite paternalistic, really.
I had a question for Don, actually. So I think you mentioned on the beginning of your talk that you were able to look at, I guess, policy between states and territories. Were you able to actually look at that in your model at all? Examining, I guess, you showed that Western Australia, for example, was really high. Were you able to look at policy differences between states and territories and how that could have influenced arrest rates?
No, when I say we looked at policy, I mean that we were interested in whether there were differences between states and territories after controlling for factors which we know at an individual level might influence the risk of arrest. No, we haven't had a chance to evaluate individual policies in the different states. And the point made about the geography of Western Australia is an important one. So it'd be great if someone wanted us to evaluate a policy. I'm more than ready. I don't even ask for money.
Right, on that note, sorry, we are well out of time now, and I think we have to move to the next session straight away. So join me in thanking all of the speakers, please.